to the demo.
This was really good.
This is a story of a 71-year-old woman who experiences sudden shortness of breath. The paramedics are called, and when they arrive, she enters cardiac arrest. She's resuscitated successfully, but when she enters the emergency department, she's in a terrible state. She has cardiogenic shock, and the lactate level is really high. The ECG shows a really weird QRS complex with elevation of the ST segment, and the lab findings, as you can see, show typical myocardial infarction. So we are there, we immediately perform an echo, and as you can see, left ventricular function is extremely reduced. So this heart is almost not pumping at all. We send her immediately to the cath lab, and as you can see, one of the major vessels is completely occluded. It is the left anterior descending. We try to open the vessel, implanting a stent, but the flow, as you can see, is not restored. And we put her on ECMO. Unfortunately, she deteriorates and she dies after a few hours.
So Anna, this is a tragic case actually, but I understand the teaching point you're making. Echocardiography certainly helps in such a situation. I mean, we saw how huge this infarct is. Now, the lab values tell us that too, but until the lab values come back, we have the echo done and we get the information much, much quicker. And if you look at the ECG, for me, it was not so easy really to interpret. Of course, the ST elevations were massive, but one could also interpret that as maybe as a left bundle branch block or as a VT. Myocardial infarction is a frequent problem, and if you look at the statistics, it is probably the single most frequent cause of death.
Exactly, and over 7 million deaths are registered per year due to myocardial infarction. And actually, depending on the presentation on the ECG, we can distinguish STEMI and non-STEMI, so ST elevation and non-ST elevation, myocardial infarction.
And the echo will be important in both of these types of myocardial infarction.
Yes, as you can see, also the most recent guidelines on myocardial infarction definition include echo in the diagnosis of myocardial infarctions.
Yes, and we perform echo not only at the moment of acute chest pain, but the guidelines state that it makes sense to perform echo also later on. So in the acute phase, but also after the acute phase, because that will provide us with a number of additional information. We see what happens to the infarct, for example, after it has been intervened. And this is an example that shows you what can happen to a patient. Here on the left, we have a patient who was imaged right at the moment of the acute myocardial infarction, and you can appreciate that there is a wall motion abnormality here, and the function is quite okay. But if you look at the same patient just a few weeks later, you see that the ventricle is now much larger and function has deteriorated. This is what we call remodeling.
But aside from acute myocardial infarction, the question still remains, what's the role of echo in chest pain? Because apart from coronary artery disease, we have other causes of chest pain.
That's completely true, but the nice thing is that with echo, we can exclude some of these causes. For example, we can detect myocarditis and pericardial disease. We can even see dissection or pulmonary embolism. So the role of echo is not only in detecting coronary artery disease, but also excluding other causes which also cause chest pain.
And still, the question remains, what's the role of medical history, ECG and lab findings?
But I guess we will ask some experts these questions.
In a chest pain unit, echocardiography is really important. You put on the transducer and you immediately see if there is a wall motion abnormality. And even though we have the ECG, echocardiography can really help you to define the problem that the patient presents with.
So to summarize, what do the guidelines say? Well, echocardiography should be routinely available in emergency rooms and should be performed early in all patients. What to look for? Well, to evaluate global LV function, to diagnose regional hypokinesia by wall motion analysis, and to rule out some differential diagnosis.
Now that we've set the stage, Let's get practical and ask the right questions.
Yes, the first question would be whether there are wall motion abnormalities, where the infarct is, whether it is new or old, or is it large or small.
Exactly. Keep these questions in mind, and we'll start now with the question, are there wall motion abnormalities in the first place? Take a look at this four-chamber view. We've shown you lots of examples in the previous chapters. I'm sure you will recognize that indeed there is a wall motion abnormality. But let us help you to assess this wall motion abnormality. And let me just start by showing you just some of the key features that you should be looking for. First of all, look at the shape of the ventricle. As I mentioned previously, the most important thing is that if you have an infarct, the ventricle is usually distorted somewhat. Look at this region here, and you will appreciate that the wall motion is not only abnormal, but that there's kind of a bulging of the septum here. So the whole apex is kind of distorted a little bit. The next thing that we'd be looking for is what is the motion of the myocardium. And definitely motion is normal down here, but right from here to about, I would say, here, there is akinesia. In other words, the wall is not moving. You will be looking at the motion of the endocardium as it is moving inward. The next thing you will be looking at is thickening of the myocardium. You have normal thickening right here, but the myocardium does not thicken right up here or in this region. This is a very important feature. Remember, however, that it is easier to see the thickening in the region of the septum as it usually is in the region of the lateral wall. This is a little bit of an exception because there's also pericardial effusion, which allows you to see the lateral wall a little bit better. The next feature that you should be looking for is hinge points. What are hinge points? Well, those are areas where you have normal contracting wall in proximity to hypercontractile wall. And in the region where these two different segments kind of connect, you would have a hinge point. And these hinge points would be right here. This is a classic hinge point. And they help you to detect wall motion abnormalities because you have a direct comparison between normal and hypercontractile myocardium. And then finally, when you assess left ventricular regional wall motion abnormalities, be aware that there are a number of conditions where you could be off. There are a number of conditions where wall motion abnormalities are mimicked, for example, as in this case, in left bundle branch block.
Recognizing wall motion abnormalities may not be so difficult, but when you want to be more precise, you can even attempt to assess the degree of wall motion abnormalities. And here's a graphic for you, which actually shows the different type of wall motion abnormalities. You go from hyperkinesia to normokinesia, and the one I recommend you focus on, hypokinesia, where the contractility is reduced, akinesia, where there's no contractility at all, and dyskinesia, where the segments have a totally weird motion.
Actually, an outward motion during systole. The next question we have to answer is, where is the wall motion abnormality? Where is the infarct? And before we do that, we need to decide on from where we're going to image the patient in the first place. Now, there are a few considerations. Usually, in an acute setting, we do not have all the time in the world, but it's not like in resuscitation. So we can take our time, and my recommendation would be to actually use the apical view.
Yes, and when you cannot approach the patient from apical view, you can still use the subcostal approach and the parasternal approach.
That's completely right. You have these options as well. Still, I would probably start with the apical view, and that's exactly what we're going to do now in our demonstration. So far, we showed you how to assess global left ventricular function, but with the help of echocardiography and with 3 simple views, you can also determine which part of the heart has the problem. For example, in the case of myocardial infarction. So how does that look if you have an infarct? If you have an anterior infarct, you would have the septum, the apex, and part of the lateral wall affected, as well as the anterior wall. If you have an inferior infarct, you would have the inferior wall here affected, and sometimes also part of the posterolateral wall here. And if you have a lateral infarct, you would have the posterolateral wall, the lateral wall here, and sometimes also part of the inferior wall affected. So more or less you can tell which region of the myocardium is affected, and very frequently you can also say what the culprit lesion is. In other words, which coronary artery was occluded. So this information is very valuable to cardiologists. For you, it is maybe not so important except in acute coronary syndromes where you want to see if, for example, the ST elevation correlates with the territory that you see in the echocardiogram. I hope this was helpful. Still, we want to show you the same thing now on the simulator because that will help you to understand the anatomy even better. It's easy to understand which segments you have if you see the anatomic image here on your left. Right, we're imaging from the front, so this is the apex. Right, this is the apex here, and this is the side, the lateral side, so this must be the lateral wall. And here in the middle is obviously the septum, which is easy to identify. If I rotate to a two-chamber view, here we have the top of the body, and this is the bottom. Here's the diaphragm. In other words, this must be the anterior wall, and this must be the inferior wall. And if I go to an apical long axis view, here we have, again, the anterior septum, we're cranial, and this would be the posterolateral wall right here. Easy to understand because we have the ascending aorta, which obviously goes cranial outside of the heart.
And here is a quick review of the views we use to assess wall motion abnormalities. We started with a 4-chamber view where we see the lateral wall and the interventricular septum. We move to the 2-chamber view to assess the anterior wall and the inferior wall. And we conclude with a 3-chamber view or long axis where we see the anterior portion of the septum and the posterior wall.
To understand the coronary blood supply, let's take a look at these anatomic figures. We have 2 vessels arising from the aortic sinus. We have the left coronary artery and the right coronary artery. The left coronary artery divides into the LAD and into the circumflex artery, which kind of passes around the heart. Now, if we have a problem in the LAD, obviously we will have a problem here in the anterior wall of the myocardium. If the circumflex is involved, the infarct will probably be more in the lateral region. If we look at the right coronary artery, which arises right here, it passes down along the bottom of the heart and supplies the inferior wall and also some parts of the septum, but we'll talk about that later.
In correspondence, these will be the segments involved in our echo. So for instance, when the LAD is involved and occluded, we will have wall motion abnormalities involving the interventricular septum, the apex, and the anterior wall. When it's the right coronary artery involved, we will have problems involving the inferior wall, the basal part of the interventricular septum, and the right ventricle. When it's the circumflex, instead, we will have wall motion abnormalities on the lateral wall as well as the posterior wall. But now let's train.
And here are the 3 apical views of the same patient, and I want you to figure out, does the patient have a wall motion abnormality? And if yes, where is the wall motion abnormality? Okay, look at the different images and remember the things we've learned so far. Well, I will help you. The 4-chamber view does not really show a wall motion abnormality in the apex. Everything is contracting normally here. Also in the lateral region. There's definitely no wall motion abnormality here in the posterolateral wall. It's almost hypercontractile. And there's no wall motion abnormality here either. But the inferior wall has a problem. This is an acute infarct. In which vessel do you think was the culprit vessel?
Well, it's the right coronary artery.
Exactly. And if you look, you will even notice that the basal part of the inferior septum also has a problem. So we made the diagnosis of an inferior infarct. And one last example. Is there wall motion abnormality here?
Yes, absolutely. When you see the lateral wall as well as the posterior wall, you see there are wall motion abnormalities and even segments which are aneurysmatic. So in this case, the artery which is involved is the circumflex.
Exactly. Next, we have to figure out whether or not the infarct is small or large. After all, it has prognostic importance and it leads our therapy. So here are 4 examples, and I want you to look at the example which in your mind has the largest infarct and which one is the smallest infarct. Okay, here is now on the top an infarct that has a wall motion abnormality right here. Here is the wall motion abnormality in the apex. So you see all of these examples have an anterior infarct. Here is a wall motion abnormality here. And here is the other one. Well, I would actually say that this one is the smallest one. Then this one, followed by probably this one, and this is the largest infarct. So in essence, this and this is probably a large infarct, and these two, I would say, are rather small. Do you agree, Anna?
Yes. And with the experience that you have now, let's go back to the clinical case and the heart I showed you at the beginning. Here, actually, you can really say this is a huge infarct.
Correct. It's an infarct that involves most of the septum, the apex, almost the entire lateral wall, and left ventricular function is very, very poor. So when you see this echo, you understand why this patient was in shock and why, sadly, the patient died.
And here's the last question for you. Do you think this myocardial infarction is new or old? Well, this is a new infarction. While the myocardial thickness is preserved, echogenicity is not higher, and indeed, this is an inferior infarct. But now, I think we are done, and you really deserve a break.